So hello, my name is Gerd Burmester. I'm a clinical investigator and scientist and physician from Berlin, Germany, from the Charité-University hospital. And I'm pleased to report the trial which was called Monarch trial. The trial had the intention to compare two cytokine inhibiting therapies. One is TNF, the other one is IL-6, in patients who were inadequate responders or intolerant to methotrexate or for some other reasons did not want to take methotrexate on board. Why is that so? We know that about 1/3 of the patients do not tolerate methotrexate or simply discontinue it. Nevertheless, we need effective treatment in these patients. So this could of course be a TNF blocking treatment, which we know is quite effective. But here we also wanted to see, is there an alternative to anti-TNF, in this case an IL-6 inhibiting agent, which is called sarilumab. It is a new agent, has not been approved yet, it's in the approval process, but it's interesting to use this in this trial. So we investigated more than 360 patients who enrolled and who were either treated with sarilumab monotherapy or adalimumab monotherapy. And we followed these patients in the initial period for 24 weeks. The patients had either been intolerant to methotrexate or had a contraindication and could no longer continue, or they had failed methotrexate and didn't want to take methotrexate anymore. And these patients were then treated with these two agents. And the outcome was DAS28, disease activity score 28, using the sedimentation rate. We also looked into other secondary endpoints like ACR responses, and also we looked into physical and mental components of the SF36. We looked into the HAQ scores, and we also looked into parameters that are not influenced by the sedimentation rate, such as the CDAI, the Clinical Disease Activity Index, either low disease activity or, as pre-specified, CDAI remission. What was the result? Well, when we looked into our patients, it turned out that quite rapidly there was a distinction between the TNF inhibitor adalimumab compared to sarilumab, so that by the end it was highly statistically significant that the disease activity was lower to a greater extent using sarilumab compared to adalimumab. This was not only true for DAS28, which is of course sensitive to the ASR, and the IL-6 is a very potent inhibitor of acute phase reactant. But it was also true if you looked for CDAI, clinical disease activity index, remission, and also for low disease activity. Obviously, it's also important to look into the side effect profile. There was no major difference between these two drugs. The number of infections was roughly the same in both groups. We discovered more neutropenia in patients with sarilumab, which is not surprising since we know that this is a class effect of IL-6 inhibition, that there are less neutrophils upon treatment. The question is, of course, does this relate to more infections? And the answer is no. There was not a higher number of infections in those who were neutropenic. So basically the safety profile was not different between these two groups. So what is the take-home message? Obviously, and I fully support obviously the EULAR recommendations that when you do biologic treatment, you should have methotrexate on board. It's a very good partner for biologic treatments. However, there are situations which you cannot do this. Obviously, if you have a contraindication to methotrexate, or the patients are intolerant, or the patient says, well, I have used that drug, didn't work, I don't want to continue. So this situation exists, and for this situation you must find a solution. So it could be either, and we know that it works, TNF inhibition, or it could be IL-6 inhibition. And this trial showed that in these particular circumstances, IL-6 inhibition, in this case we used the agent sarilumab versus adalimumab, that IL-6 inhibition was superior in monotherapy compared to TNF inhibition.